Good morning or good afternoon, everyone. We will start our webinar in about 1 minute.
Feel free to say hello in the chat. Or just say hello. I don't know. Can we hear everybody?
And if you already have a question for today's panelists, you can go ahead and put it into the Q&A right now. For those who just joined us, we'll be starting our webinar in about 30 seconds. And just to let everybody know, the discussion function is turned off. If you have a question for a panelist, you need to use the Q&A. If you have questions regarding technical issues, please put it into the chat. And also feel free, as Mike said, to say hello in the chat if you wish. We'll start our webinar in about 15 seconds.
So far, no one's saying hello. I just see like 2 chat things.
It sounds like the chat is disabled, just the Q&A works. So
I see.
they cannot
All
chat,
right.
but they can.
Gotcha. Well, there you go. Let me check the Q&A.
You can say hi in the Q&A as well too. All right, I think we will go ahead and get started because we have a terrific webinar for you today, and I think there's going to be a lot of discussion, so I want to give our panelists as much time as possible. So welcome everyone to the California Telehealth Policy Coalition webinar on cross-state licensure and compacts. My name is May Quall. I'm the Executive Director at the Center for Connected Health Policy, which is the convener for the California Telehealth Policy Coalition. Next slide, please. Next slide. So first off, I would like to thank today's sponsors of this webinar is the California Healthcare Foundation and the Center for Connected Health Policy. Without their support, we would not be able to do these educational programs. So thank you to our sponsors. Next slide, please. A bit of background about the California Telehealth Policy Coalition. It is a coalition of over 170 different state and national organizations who are interested in California telehealth policy. CCHP acts as the convener for this group. If you are interested in the coalition or interested in joining it, please reach out to CCHP and we'll be able to get you connected and more information regarding the coalition and the work that we do. Next slide. Today's webinar is on cross-state licensure and the licensure compacts. We hope to provide you with an overview of these issues, highlight some of the attempts made in California regarding licensure and compact legislation, but more importantly, want to hear from experts and stakeholders on their perspectives regarding interstate compacts and cross-state licensure, and hopefully answer some key questions around these issues. Next slide. We'll start off with some foundation level setting on licensure and compacts provided by Amy Durbin, my colleague at the Center for Connected Health Policy, followed by a panel of experts and participants moderated by Mike Curlin from MedFont. We will remind you that if you have a question for our panelists to please put in the Q&A. Today's webinar is being recorded. The recording will be up on CCHP's website within 48 hours after this webinar. Also, there will be a brief survey after this webinar, and we would really appreciate it if you fill that out. And without further ado, I will now turn it over to Amy to provide you with your overview.
Thank you, May. So yeah, I'm just going to give a brief overview of the licensure landscape nationally, as well as highlight California's policies in that regard. We can go ahead and go to the next slide. But CCHP tracks telehealth policies federally and across all the states, DC, as well as Puerto Rico and the Virgin Islands. And we've started categorizing cross-state practice licensure policies into 3 categories. The first being limited licensure exceptions, then telehealth license or registration processes, as well as interstate compact membership. The limited licensure exceptions capture any kind of exception, no matter how limited or specific, including provider-to-provider consultation exceptions, as well as broader allowances related to established relationships and frequent interactions and/or certain types of care, such as in instances of emergency or specialty care, mental health, or life-threatening diseases. In addition, telehealth license registration processes and compacts might not always be active. However, some type of authority or process was found to exist in state policy. So CCHP has found 36 states to have limited licensure exceptions, with those provider-to-provider consultations being the most common. And then 20 states have a telehealth license or registration process, though they might not always go by that name. Some states call it a waiver, or permit, certification. And then most states are a member of at least one compact, with only 5 territories not currently being a part of any compact, including California, which also doesn't have a registration type process, but does have some limited licensure exceptions. So until last year, those exceptions were just related to provider-to-provider consults. However, 2 bills passed in 2023 that created additional exceptions. One is AB 1369 that now allows out-of-state physicians to treat patients in California via telehealth with immediately life-threatening diseases. And then AB 232, which authorizes certain behavioral health providers out of state to receive temporary practice allowances in certain instances. California has had compact legislation attempted in the past. However, with 3 bills introduced this session, AB 2051, which would have entered California into the psychology interjurisdictional compact, AB 2566, which was related to the counseling compact, and then AB 3232 with the nurse licensure compact. AB 3232 was never heard in committee, but the other 2 did pass the first house this year once amendments were taken to hinge official enactment on approval of the respective boards and Department of Consumer Affairs certification of that approval. The California legislature and boards have always been a bit skeptical of compacts. There was an informational committee hearing earlier this year on compacts that showed some of those concerns and whether entering into compacts would be beneficial for California providers, how oversight would really work and interact with other state policies that might be in conflict with California protections. So ultimately, the 2 other bills were held in the Senate as well this year. And then we can go to the next slide. But we also thought a quick overview on how compacts work might be helpful context for this webinar. So as of today, there are 17 occupational licensure compacts, although 2 are specific to occupations outside of healthcare and 2 are still in development. Some are still relatively new and not fully active or issuing licenses yet at this time as well. We also list some of the most popular and growing compacts across states, as well as some of the key components of how the compact process works, although the structures, fees, and privileges provided by each compact does vary. So they're specific to certain licensees, created through a stakeholder process that does try to keep state autonomy over practice acts and licensure processes intact. Once a compact is developed, it must be passed through a state's legislative process as initially drafted without changes for a state to officially participate and the compact to be enforceable. However, not being able to amend the language to reflect different state priorities can sometimes be a concern for states. And then once a certain number of states adopt the uniform language, it becomes active, and then an implementation process begins prior to the compact being able to issue licenses. With administration governed by an interstate commission made up of member state delegates. Another issue that's come up in California's conversations on compacts and how that makeup may or may not appropriately reflect the number of licensees brought in by each member state. But with that, I believe we're going to get into our panel discussion, discuss some of Washington's policies in this regard, and other perspectives and experiences related to those types of licensure policies with our panelists.
Thank you, Amy. And before I hand it off to our moderator for today, Mike Curlin, just want to answer some questions I've seen in the chat. Yes, the PowerPoint will be made available along with the recording. Again, that'll be about 48 hours after this webinar. And without further ado, I now turn it over to Mike Curlin, who is Vice President, Clinical Quality and Integration at MedOne Solutions. Mike.
Thank you, May and team. Good morning and good afternoon, everyone, and welcome to our webinar on cross-state licensure and compacts. Well, as we all know, telehealth is one of the ways healthcare has been changing. Its use is really inevitable given the resource constraints and demands of our population. Ultimately, it's making it easier for everyone to get the care they need where they need it. But one of the hurdles practitioners face is multi-state licensure. It can be a pretty complicated, time-consuming, and expensive and frustrating process to apply for a license in every state you want to practice in. And that's where these compacts come in. Ideally, they give states a chance to collaborate on a common approach. letting providers practice across state lines without jumping through a million hoops. And since telehealth is considered to be rendered where the patient is located, it's really important that licensure boards in both the providers and patient states oversee the care being provided. This ensures safety and accountability, right? Sounds simple. So if it's that simple, what's with the territorialism around licensure? Well, with the panel, we'll dig into these questions. We'll talk more about why compacts are really needed, bust some myths, and maybe cover some of the foundational underpinnings of setting up a compact if we have time. We have a fantastic panel lined up to share their insights. And one reason why I'm really excited that I'm talking to this group is because they're going to tell you the real deal. So let's just get started. I'd like to first bring Micah Matthews up. Micah, can you start off by introducing yourself and giving us an overview of the process and the regulatory perspective related to drafting, adopting, and implementing compacts, as well as Washington's limited licensure exceptions?
Sure. Thanks, Mike. My name is Micah Matthews. I'm the Deputy Executive and Legislative Director for the Washington Medical Commission. We regulate physicians, physician assistants, and now certified anesthesiologist assistants in Washington State. I've also been on the telemedicine policy scene for about a decade, working with groups on the West Coast as well as in Washington, D.C. And for full disclosure, I also sat as an observer with the Uniform Laws Commission as they drafted their uniform telehealth law in 2022, 2023. So to answer your question, Mike, generally, these compacts get started with HRSA funding as a grant, and they'll bring forward the professionals, associations, regulatory representatives. And you discuss the concepts after getting presentations from groups like the Council of State Governments, or maybe a national organization such as the PT, National PT Group, or the National PA Group, or something like that. And so they present models for consideration. And you debate that with the people that are there. And at that point, you put together a drafting committee and you write a model compact law. I want to stress that the process is iterative on this. It does require numerous feedback points, and the best rollouts that I've seen are ones that have multiple rollout points to get multiple levels of feedback. The medical licensure compact did a pretty good job with that. PA compact, not as much. They got quite a bit of pushback at one of their rollouts where they didn't incorporate some pretty uniformly put forward concerns. They were both unveiled at the Federation of State Medical Boards annual meeting, and with the differing receptions, I said. So at that point, it's up to the stakeholders to decide to move forward with adoption. And once it's passed into law and you hit your trigger threshold of activation, which in general is about 7 states adopting it. And I want to emphasize, you have to adopt the exact same language. Otherwise, according to legal counsels, you've created a compact of 1. So that doesn't help you. So once you've tested, so once you get it passed, you get to the implementation bits, and usually it's working with technology folks and setting up a process for that. And once you've tested it, you open it up. So our experience with the medical licensure compact is we had to launch it in 2 phases. The first was the easy one, where you get the reciprocal license where someone's from another state and they want a license in your state. We were able to launch that the first year. There were some issues that were not directly sitting with us. Just as an FYI, the FBI is very, very clear on who they think should have access to their information. And there were states that absolutely did not have the right language in statute outside of the compact. And we had language that we had been relying on for decades in statute, but they still were pretty skeptical because this was a new process. And that held up a lot of other states. Minnesota in particular thought that they were ready to go, and right at the last moment the FBI said, you're not accessing for the purposes of giving us a state of principal licensure verification. So once you have that and you're ready to go, you'll launch it. And I will say that inevitably there is a surge when you first open up as a state. But you also have surges when other states come on. So an example is we estimated that we were going to get 70 compact licenses per year. We've issued over 5,500 since 2019. And every time a new state comes on, say like Texas, we get a massive surge of applicants. So it's been heavily utilized, but you do have to staff up for it. With respect to the licensing exemptions, those are really a separate conversation from compacts. Washington's historically been pretty liberal about those in a non-political sense. We've had these exemptions in place since 2016 as policy. In 2020, they were passed in the peer-to-peer exemption was passed into law, and now all of our exemptions are included in the Uniform Laws Commission Uniform Telehealth Act that was adopted by Washington State in 2024. So as a primary author of those exemptions, I'm pretty in favor of them, but I recognize I'm biased. And my perspective is as follows. We've had them in place since 2016, and we have not had significant issues with them with respect to just rampant unlicensed practice or anything like that. There's a variety of factors that influence license holders and non-license holders. And the thing that I think you've got to consider when you're looking at licensure exemptions is physicians have education, training, awareness, and agency to push back on corporate motivations and things that are not patient safety focused. As those aspects of the professional are reduced by, whether it's a different profession with less training or less education or less agency, there's increased likelihood for abuse when getting direction from, say, on high about how they're going to behave or utilize telehealth. And so when you're looking at exemptions, instead of a blanket, you must all operate with these exemptions, you need to be a little bit cognizant that some professions have more agency than others to push back.
Thank you for that really comprehensive and enlightening answer. Just out of curiosity, when you said that 7 states have to basically get the same exact language and everyone has to agree to it, how long in general does it take to get a compact across the finish line?
I think it depends on the state and the compact. But even in a state like Washington, it took us 2 years to get the medical licensure compact through. And that was with the nurse compact already in existence, and people felt like they knew what it was. But we got a bunch of pushback on what is this? Is it going to overrule our Constitution? What is the concept of res judicata and overriding state law for the purposes of a conflict? So that was 2017, 2018. This year, the PA compact, it was pre-filed in December. Legislative session went live in January, and that thing was passed before the second cutoff in February and on the governor's desk. And there was almost no debate. They just wanted to make sure that we supported it, and they were gone. So that's the policy of Washington State has turned into we support compacts, and they're passing just about every single one that comes across, for better, for worse. And the worst piece, I would say, is not necessarily worse, but there's impacts. So the nurse licensure compact got passed this last session in Washington. That's had a pretty significant fiscal impact that is having to be reckoned with by the board. And that's been a known issue. That's probably why you would say that DC doesn't, I don't believe they have passed the nurse licensure compact, because they share so many different state nurses that you would effectively defund the board.
That's another thing to consider. Thank you. I'm going to turn to Dr. Helen Hughes. Please introduce yourself, your organization, and if you can, provide an overview of your work and the perspective related to your view on licensure and compacts.
Excellent. Thanks so much. I am the medical director of the Office of Telemedicine at Johns Hopkins. We serve the operational and technical deployment at telemedicine at all of our sites, which includes hospitals and ambulatory sites in Maryland, DC, Virginia, and Florida. And I really come at this from an operational standpoint. I saw us going from 800 pre-COVID telemedicine visits to now 2 million. We went from 50 per month pre-COVID to 100,000 per month in May of 2020, now to about 30,000 per month. Telemedicine is about 12% of our outpatient care. And we have a lot of very specialized specialists in our tertiary quaternary care environment who will see only a handful of patients in each state. So really trying to solve the problem of how do you have a process that's easy enough for a clinician to do for maybe 3 or 4 patients a year, but also safe for patients and makes sense for states and other regulators. We're very appreciative of all the compacts. Some of them are quite challenging for our providers to complete themselves if it's only going to be for 1 or 2 patients. And they're also hard for us to operationalize in terms of our scheduling systems to know, our EHR doesn't clearly know when people are in compacts, and it's hard to get that logic into scheduling. So we're thinking about what are some national approaches that might be possible for sort of rare and high impact conditions, and looking forward to talking more about that today.
Nice. Thank you very much. It seems like there's so much to cover, so I'm gonna jump to Kelly. Kelly, please introduce yourself, your org, and provide perspective related to licensure as well.
Yeah, thanks, Mike. Hi, everyone. I'm Kelly Goss. I'm the Managing Director of Advocacy at the ALS Association. I'm based in Sacramento, California, and I cover California as well as a few other Western states. So what I'm going to start off talking about today is the bill that we worked on that passed and signed into law last year, AB 1369, which is a narrow telehealth exemption for those with terminal conditions to receive care from a provider who is out of state and licensed out of state. And what this bill does is expand upon existing California law that allowed only in consultation with a California-based provider. This bill was authored by Assemblywoman Rebecca Bauer-Kayan, and she had initiated this legislation based on a dear family friend of hers who had a terminal cancer condition. And just upon hearing his story and that of his family having to go travel interstate to receive the care that they needed for his specialty disease, and how advanced and how grueling and burdensome it was on them. And so she prompted this legislation, and her office reached out to our organization to see if we were interested in getting involved, which of course we were. And that, I should say too, for those of you that aren't as very familiar with ALS and what it is as a disease, it is a progressive neurodegenerative disease in which the average life span from point of diagnosis is 2 to 5 years. And so our patients have, because of the progression nature, it is a rare disease as well. So because of the progression of the disease, they lose mobility over time, as well as their ability to speak and their ability to eat, drink, and then eventually their ability to breathe. And so because of the mobility restrictions in particular of having to travel out of state to see a specialist, if that's, or, participate in a trial, which has a different set of regulations, so I'll leave that aside. We recognize that this was really important for our patient community, and that we wanted to be involved in the legislation. And again, as I described, it is a narrow exemption that is only for those who are terminal or deemed terminal. It's built on the concept of the right to try legislation, which passed in California in 2018, and which allows patients to utilize drugs that manufacturers produce prior to FDA approval, of course, at the manufacturer's discretion. And the idea there behind that and the concept of AB 1369 is that those that are deemed terminal have a different mindset in terms of the risks that they might take in seeking treatment from a provider that isn't licensed necessarily in California. And so we felt this legislation was a good thing for not only our ALS community, but other disease areas, particularly you can see it wanting to be utilized in other rare disease space. You see a lot of pediatric rare diseases, for example, where there's only 1 or 2 specialists across the country, and they're not based here in California. We recognize, of course, that California has we're very blessed in the sense that we have fantastic medical institutions and tons of providers and specialists in many areas, but there are gaps, and there are gaps that still need to be addressed. And then there's also the issue of patient choice. And if a patient wants to receive a second opinion, for example, and they want to go out of state to do so, that they or to consult with a licensed provider, out of state, they should have that ability to do so, particularly in the gravity of the disease, and the nature of it, of somebody with a terminal or a very serious condition, that the burdens that, that they face between the, physical, mental, and financial hardship that they would incur. The other thing I would just mention too is that, for the ALS Association, telehealth is among our state policy priorities, and it's expanding access to it, because again, the gravity of our patient population, our ultimate goal is to see all states sign into the compact. We see that as the sort of the gold or platinum standard, if you will. And with that, and I'll mention that Alaska just this year passed a telehealth bill, SB 91 by Senator Matt Clayman. That was just signed into law this past month and will be enacted this fall, which extends it to the multidisciplinary care provider team. So that's a great achievement as well, because particularly you look at a place like Alaska, where you have tons of rural areas, patients having to travel incredibly far to receive care. This allows them, once they have that initial contact with the doctor and the multi-care team, which includes many other licensed specialties and non-licensed specialists, then they can receive telehealth care from their home and not have to do every visitation in person. So happy to talk more about either of those bills, and looking forward to the discussion that will ensure. Thank you.
Thank you. Before we transition over to Tyler, just kind of a quick summary, can you just inform folks, just like a quick lesson learned or just a piece of advice about these more narrow exemptions? Like, should they go for it? Are they more accepted?
Well, I will speak to the case in California. So the probably the most opposition that we faced was actually the concern from the medical licensing board, including the osteopathy board here in California, as well as the medical board itself, who was on record in opposition of the bill. They didn't see it as necessary. We worked very diligently with their office and had really good conversations. Definitely understand their concern, but again, if the goal overall, like I think they were willing to, well, I don't want to speak for them. I think they were willing to sort of fast track the licensure process, but their concern clearly had to do with how do we have jurisdiction over these people and prevent bad actors. I think in the case of this bill, as I alluded to earlier, the issue for us was, again, somebody with a terminal diagnosis has a different mindset in terms of what risks that they might be willing to take to receive care that might ultimately give them a prolonged chance at life and a better, quality of life while they're still living. And so we didn't see that as the right solution. And so again, we were able to get this bill through the legislature. But I think just being aware that, how you look at these, I think the natural next step for in California would be to expand upon AB 1369 into at least all rare diseases that, so that would like remove just the terminal condition and look at, because again, there still is this huge existing gap, particularly in the rare disease space, where you have only, as Dr. Hughes already mentioned as well, only a few specialists around the country in a few places that see just a few patients. And so the way we should be framing this is what makes the most sense for patients to receive the care and minimizes the burden upon doctors in good standing, of course, that are providing care, and they can't be everywhere. So how do we want to frame this to make everything as efficient as we can? The goal is for patients to receive the best care they can wherever they can receive it.
Thank you. That's a great soundbite that we should probably record right there at the end. Tyler, thanks for hanging in there. Would you mind introducing yourself and your perspectives on licensure and compacts?
Sure. Good morning, everyone. Tyler Rindy. I'm the Director of Government Affairs with the California Psychological Association. We represent licensed psychologists across the state of California. One of the way that we're intersecting with this year is that there was a bill that was introduced in the legislature, AB 2051 by Assemblymember Mia Bonta, which would have had California adopt and enter into the Psychological Interjurisdictional Compact, or PsyPact for short. Our board of directors ended up voting for a support if amended position on the bill. The SciPact or SciPact is been adopted in 42 out of the 50 states, and I think one of the territories, although don't quote me on that. And it allows for temporary temporary in-person practice, and then authorization to practice telehealth across state lines. Our main, vantage point on this has been that while the model law allows for individuals that went to doctoral programs that were regionally accredited to participate, the actual implementation of SciPact has restricted the authorization to practice across state lines only to individuals that went to programs that were licensed by accredited by the American Psychological Association. So that ends up restricting about 34% of California psychologists from participating. So our vantage point on it was that California should not join SciPact until the commission ends up aligning with the Model Act so that more psychologists in California can end up participating. And we don't have a situation where our psychologists can't participate, but individuals from out of state could end up coming in and working in state through SciPact. And just to note that only 10 states and District of Columbia require APA accreditation for their licensure. There's about 40 states that do not require it. So maybe I'll stop there, and happy to dive into a lot more of the issues that we're facing, or kind of brought up into the discussions of the bill this year.
I'm curious if you could just give everyone just a little bit more about the APA, that criteria that you just mentioned, like, and one in California, because I think that's a nuanced piece of information that, unless I was part of this group, I would not have known that that's why things are being held up.
Yeah, so the APA accredits a significant portion of programs across the state, but there's also what we call regionally accredited bodies. So this includes, I think it's BOSC, which is the Western Association of, I'm actually not going to get it correct and stuff. So I'm sure someone else on the line can, but they accredit a significant number of the schools in California. We've heard that California has the most number of schools that are not APA accredited, but they contribute a significant number of the licensees in California. Also, there's no data that someone who went to an APA accredited school is more qualified or, more of a risk to a consumer and stuff. And so we viewed it as something that is, there needs to be equity for individuals that went to those schools. And there's no way to end up correcting it after the fact. If you went to a non-APA accredited school, you can't 5 years down the road end up, changing where you went to school in order to be able to actually participate in SciPact. So it kind of locks these individuals out significantly from participation.
Thank you for that. Micah, I'm going to jump to you. Following up on regarding the Washington policies that were adopted, can you share why Washington chose not to pursue a registration process as part of the licensure policies?
Yeah, there's a few reasons. And I'll very quickly sum through them. So existing efficiencies was one. We're already quite fast with issuing a license. A standard license in Washington state takes max 4 weeks. In our busy season, it's 5. If you are coming through the compact, which I think has 42 states now, you're getting it in 3 days or less. And that's 99% of those. So there wasn't an operational need in that sense. The next one is confusion. I oversee licensing in Washington, and the number of folks who are applying for the wrong type of license, MD versus DO, or resident versus fellow, or clinical experience, IMG versus a resident of some other kind. It happens all the time, and it's adding a registration process would simply add to more confusion on that. We've tried to make the other ones as simple as possible. And so I would say the final thing that's the most problematic for us is there's too many similarities legally with licensure. And what that means is our state constitution and most other states recognize that the medical license is a property right. And therefore, you have a higher burden of proof in Washington, especially. Clear, cogent, convincing is what the standard is to be able to take any action on that license. There would be no difference between a license and a registration under that framework of law. And so that it didn't make sense to create something new that would add more confusion where we didn't have a lack of time and would still have the same standard of proof there. And then finally, under the Uniform Laws Commission standard that they have for that, the process would largely be the same as licensure. You're verifying the same information. And I think as we talked in the prep call, there was some misunderstanding with respect to the process. You know, as they were drafting, they were like, oh, they just have to complete an application, send in their money, they automatically get it. And I had to really go, you know, hey, pump the brakes. They still have absolute discretion in issuing something. And if they find a disciplinary issue, they can deny you. And that has implications with the National Practitioner Data Bank. You know, the Physician Data Center run by Federation of State Medical Boards reports out to the other medical boards. So there's a number of reasons, and those are the ones that we had concerns about. I think just providing some insight, it looks like all of the stakeholders are pretty uniformly against that registration process, and that looks like the recommendation that may come down from the telehealth collaborative in Washington about what would happen in 2025.
Interesting, because registration seems like it's a favorable option for states as well. So I'd like to circle back to that at some point. Maybe that's a myth that we can bust. Dr. Hughes, you were involved in the implementation of state waivers during the PHE. Can you share about the impact of licensure waivers while they were in place and the changes that have occurred since their expiration?
Absolutely, certainly. Well, going back to the pre-COVID state, California may have been different because I believe Medi-Cal covered telemedicine visits with patients are at home, but Maryland Medicaid did not, Medicare did not pre-COVID. So we had very little telemedicine. So it really wasn't an issue because it wasn't really happening. But we did probably have out-of-state interactions between patients and their providers, whether it was MyChart messages or telephone calls. And then all of a sudden, you know, we converted about 70% of our outpatient visits to telemedicine by May of 2020. For us, I think about up to about 14% of our care was out of state during that like peak COVID period. And it was really extraordinary to try to it was such a Rubik's Cube of provider type, state, and try to articulate that. We had color-coded maps. It was really complex. But I think in general, people just provided the care that patients needed in those early stages. And then about a year and a half in, as slowly states' waivers expired, it was quite chaotic to try to articulate that to providers. And again, we had kind of color-coded maps that we sent out each week. And it was hard to get our electronic systems to catch up with that. So now we're essentially back to the pre-COVID state. I think I'm hearing the negatives to registration. Our providers do love the Florida telehealth registration because it's so easy. It takes like 10 to 15 minutes. Florida does the work to check with Maryland that you can be registered. You get it in about a day. So it is easy enough to do just for a handful of patients you're going to see in Florida, maybe who are snowbirds. We've also been appreciative of Virginia has a established patient exception for 12 months. They also have a reciprocal relationship with Maryland where you can essentially get a licensure in a day. So we see some things getting easier, but we really want to be able to have things that are operationally feasible. The registration's nice because we can put it in our EHR saying, this person's been registered in Florida, you can schedule them with Florida. Patient conditions are nice because you can say, this is an oncology clinic, you can schedule patients in another state. But some of the more nuanced exceptions and compacts are harder for us to operationalize.
Wow, thank you. It's funny that you even brought up Florida. So hopefully we have a little bit more time towards the end. Kelly, just curious, are there other notable bills the ALS Association is supporting or watching in other states related to licensure?
Yeah, I know several of my colleagues that cover other states are engaged in monitoring telehealth and telemedicine, both within state and of course out of state. Again, our focus is the patient getting the we're always focused on the most access to care. So, and in a timely manner, because again, a time is not on our side, given the nature of the disease. So yeah, so we're engaged in a number of bills, like constantly monitoring bills, and where can we expand here? Where do we have the most options when we look at going into, for example, with most state sessions done for this year, we'll look at going into next year where is most feasible or makes the most sense. But the most recent achievement was the Alaska bill that I had mentioned, SB 91, which, by the way, does have a registration component to that. So again, that bill is premise, just as Dr. Hughes said, on an established relationship. So the Alaska patient has established a relationship with the doctor and multidisciplinary care team out of state, and then can do telehealth within. So from that point forward, and of course, there's other considerations too, because you look at, first of all, I would say too, for ALS specifically, I don't think there's a provider out there would say that they want to see the patient in person, at least on, as to the extent that they can, because that's the nature of disease would that you're going to receive the best care in person. They can monitor you in person because of the physical nature of the disease. However, we recognize that the patient needs care, and we see better outcomes when the patient has continuity of care and can be seen in, in time intervals. And so if the patient can have, you know, intermittent appointments in telehealth, so that they don't have the grueling aspect of having to physically travel, that's a huge win for them. And then what I was going to mention too, that for most of our patients, or about 2/3, are on Medicare, because ALS has immediate access to Medicare regardless of age, and so Medicare does require that patients are seen in person at least once a year.
Shifting over to Tyler, and thank you for that answer. I did not know that about Medicare and that requirement. So it's something that outside of the states needs to be considered as well. Tyler, are there other issues that came up during the compact legislation process this year that that you're aware of that may have influenced the legislature's decision not to have the bills move forward?
Yeah, thank you for the question. So yeah, there was in addition to, which our primary focus was on, individuals going to that went to regionally accredited schools being able to participate. Some of the other things that came up in the discussion, particularly from the Board of Psychology, California Board of Psychology had adopted an opposed position on the bill. And in the most recent version of the bill, before it kind of stalled out this year, was that the Board of Psychology would have to vote to approve PSYPACT, even if the bill had passed and been signed by the governor. Some of the things that they had brought up in their letters and in discussions in the legislature was concerns around ceding authority from the Board of Psychology and from the state of California to a non-governmental entity that exists out of state, that California would end up having one vote on the commission, even though that they would end up contributing substantially more licensees than other states. California has the highest number of licensees out of any state. And then some of the other things that had come up was just concerns around California's continuing education requirements. California requires 4 hours every 2 years of time learning and relearning of California's law and ethics, and then also on 4 hours of diversity and social justice. And so one of the things that had come up was concern around whether, even though individuals under PSYPACT have to follow the rules and laws of the state that they're practicing in, that they would not know what the laws and rules are of California and some of the contemporary values of California. So particularly in the discussion had come up around California has prohibited conversion therapy for LGBTQ children and youth. And California also, prohibits mandatory counseling for a woman who's seeking an abortion. And so some of these issues were, made, I don't want to speak for the legislature, of course, but these were things that had come up as, concerns that were held by the board and some of the members of the legislature. So I think there's multifacets to, any of the adoption of the compacts, especially because the compacts require an adoption in full. You can't take, as Micah had said, you can't take pieces and parts of it and separate them.
Thank you. And building on that, and I think somebody had mentioned common sense, like a common sense approach. Maybe it was Kelly. For all the panelists, and I guess you guys could kind of like whoever goes first, like, are there some, common sense exceptions or specific situations where there should be license reform and where it makes the most impact right now, where like, okay, guys, this is, we need to get this across the line? Kelly, you first. All right, since everyone's being nice.
Thank you. So as I said before, I think ultimately we have to look at it as what is it we're trying to achieve, right? And can we do something that works for all sides of the equation, right? So, again, we're trying to ensure, I think everyone would agree, if whether you're a provider or the patient, we're trying to ensure that patients receive the best care they can. And we have to recognize, while there may be, and I'll speak for California, like we have fantastic medical facilities and providers here in the state, but there are still gaps both within the state as well as needs for patients here to go elsewhere for care, whether it be for an unbiased second opinion that's out of state by specialists, or for care that is just highly specialized and only available in outside of California in a limited number of places. And so I think we just need to take a practical approach of how do we achieve that and make it flexible enough for providers out of state to comply or to be, upstanding. And how do we measure that is really sort of the magic question, in terms of, like, I understand California's need for quality control and ensuring that whoever the licensee is up to standards, but we also have to be flexible enough to make sure that in and of itself doesn't prevent the patient from receiving the care that they ultimately need.
Thank you. I'm going to jump to Helen.
Yes, yeah, I wanted to echo what Kelly's saying. Ultimately, we're getting pretty impatient. We have 3 years worth of pretty much weekly emails of patients begging to be able to see their provider. And, we appreciate all the state-based work that's going on, but I have a hard time believing that we're going to have all 50 states do the same thing in a short period of time. So we try to identify what's the most urgent, and also what doesn't intersect with anything related to reproductive health care or other care that really differs across state. And for us, that's cancer care, transplant care, rare diseases, clinical trials, and college student mental health. So we're, trying to coalition build, and we welcome outreach from anyone around. Could there be a possible federal approach like the VA or like the Sports Medical Clarity Act that could be for those kind of common sense, urgent, very unvariable use cases where there's not a lot of state to state variability?
Thank you. How about Micah and then Tyler?
Sure. So I think when we're talking about common sense, the exemptions related to the border state, which I know we're pretty biased with respect to the borders we have in Washington. And we've got some weird exemptions when it comes to Point Roberts in Canada, which is technically US, but it's completely surrounded by Canada and a body of water. So those are some good ones. I think the university student, the vacation, the specialist assessment, the temporary work assignment, all of those I think are common sense and have proven incredibly useful in practice. I think the biggest debate that we experienced this year was, and I will say that I was deemed heretical for years about trying to advance these things. But this one we got through was moving the line from you need a license no matter what to you can assess, diagnose, and recommend treatment without a license. And specifically, we specified primary care, mental health, and recognized clinical specialist. And I recognize also that a recognized clinical specialist is a very broad term. That was intentional. And so that's to our mind, basically the model is, if I need to talk to a clinical specialist or whatnot, and I can do that and talk to them, get assessed, to get diagnosed, and get a treatment recommendation. They can either at that point split off in 2 camps. They either can coordinate with an MD on the ground and have that peer-to-peer exemption, so no licensure is required there, or the patient can travel, and in a lot of these cases, they do need to travel for an initial treatment setup. Most clinicians I speak with are not comfortable initiating brand new treatment, especially something that is complex or dealing with a complex disease. They want the patient in front of them in case there is some sort of adverse reaction. But at that point, they've established that treatment relationship in the state where the patient is. The patient comes back and they're in, at least in Washington or whenever someone passes the uniform law, you don't have to have a license for that follow-up continuity of care. So there is a lot of common sense there. You don't get, if you look at the overwhelmingly, and I guess I'll just end with this, telemedicine is medicine in so many different assessments. And if you look at the overwhelmingly negative responses to the proposed DEA prescribing rules that were impacting telemedicine, I think you'll see that regulators, the profession, employers, almost all the industry was completely aligned on that. It was ridiculous to try and say this is a telemedicine prescription before you send it to a pharmacy. It just didn't make any sense at all. So I'll end with that.
Thank you. Tyler?
Yeah, I would just add, California has an existing 30-day limited licensure exception for out-of-state psychologists to practice in California. I think the thing that we see is that not every other state, some of them have registration requirements, some of them have, it's maybe up to 5 days. It varies all across and stuff. And so we, even though we have our concerns with the compact, we do view that hopefully, with some changes to the compact that we could end up entering into it with the hope of, to help solve some continuity of care issues. And that really comes down to, we see, as Helen had mentioned, college students going across state lines and stuff. They may not be established with a new provider, or they come home for the holidays or travel, and just the ability to end up continuing to see the same, service provider really would end up helping. I know this is something we often hear from our psychologists is, someone's traveling and stuff, or, the psychologist themselves is traveling out of state. And just the ability to have continuing continuity of care would be really helpful for our patients that our psychologists serve.
Absolutely. Well, we have a little bit more time left. I'm going to ask each of you just to squeeze in either a myth that you would like to bust, or if you want to make your kind of like stand on the registration or registration process. So we could kind of cover one or both, cover whatever one you want. I'm going to start off with Helen.
Yeah, I think I can't overestimate how important it is for it to be easy for the providers. Our providers are already overburdened and are quitting the profession because of too much electronic health record documentation. To ask them to do 50 5-hour processes to get licensed in every state. I know the compacts are quicker, but it's still more work for them additively. So anything that goes forward would need to be easier for providers.
Thank you. Tyler?
I would just echo what Helen said around just easiness for the providers. I had heard a case yesterday and preparing for this where, a provider, it's 5-day limited licensure exception, but it can take up to 2 weeks to end up getting getting it. So it's just not worth it for the provider to end up pursuing.
Kelly.
Yeah, I concur with both what Tyler and Dr. Hughes just said regarding streamlining the process, because that in of itself is the challenge of, we were asked numerous times during the process with AB 1369, why can't the out-of-state licensed provider elsewhere, just apply for licensure in California, and then we wouldn't be dealing with this. And the reality is they don't, for the very reasons that she stated. So we need to come up. So because of that, and then we know that the patient may have needs that to be seen and treated elsewhere, we need to come up with a solution. And it's not necessarily as hard as it needs to be. The sky isn't sort of falling. That said, we want to safeguard and make sure that I understand those concerns, and we need to be practical about it. And I think Micah has provided a lot of really great information with that regard, but we have to just sort of carry through to make sure that ultimately we're receiving the goal that patients get access to care and providers can do their job that they're trained to do.
Thank you. Micah.
Sure. I think just circling back, the compacts and common sense exemptions are, I think, are the most robust and flexible options, that especially if you have well-designed exemptions and the associated communication about them. I think word getting out about those is more important than I think anything else. And it, in my experience, it does reduce waste. I will say, and again, here's my heretical stance among regulators coming out. I do hope for another evolution in regulatory approach for this. And it's, as I said before, it is an iterative process to move folks down the line. We came out with those exemptions in 2016, proposed them to FSMB in 2017, and I was laughed out of the room in 2017. Then the pandemic came along and everyone started getting creative and looking to what we'd already established. So with that being said, I do participate in international groups, and so there's a concept called a national practice registry. And if you're wanting to know more about it, Australia, Canada, the UK, they all have it. You basically come through the regulator and you are granted access in that province. And in some cases, say Australia, you have the ability to practice nationally. I think it's a bit more complex because we're dealing with 70 jurisdictions in the United States that would have to agree to it or be forced into it on a federal level. But through the regulator, you could grant this aspect, you could reduce further waste and make it fairly easy. I think the details that are difficult are funding, operational authority, jurisdictional authority. I mean, it's a pretty fundamental change. And without getting too political, I will say that the until last year, it looked like we could move forward on this. And then Dobbs happened. And the Dobbs case has completely upended the trust factor among regulators and the associated entities about what could happen to our licensees from another state and what negative aspects could occur. And we've already seen that in Washington. I think I gave the example, AG Ken Paxton was trying to get gender affirming care records from one of our state hospitals, and we were able to shut that down. But there's other avenues to where that information can get pulled legally and address harm against practitioners and thereby reduce the workforce. So hopefully more to come on that, but we do have to work out some pretty fundamentally concerning legal opinions at this point.
Thank you. I want to thank the panel for a very, very informative discussion. I'm going to pass the baton back over to May and team. There's probably ways that we could all get in touch with everyone that was on the panel, and CCHP obviously has a lot of tremendous information and contacts available. So I ask you guys to reach out to May and her team. And if there was anything that wasn't covered, please do submit that.
Thank you, Mike, and thank you to our panelists today. That was a great discussion. Also leave some questions for us and some more policies, as Micah referred to, that we need to further explore and try to understand as well too. Sorry we could not get to all of your questions today. Please note that you can reach out to CCHP to ask your questions and we will try to answer them. A couple of things on there, people have asked where they can find more information about the compacts and what states are in which compact. We have some of that information on our CCHP website. If you are interested in a particular state, we do list what compacts that they are currently in. So that is one source that you can look at. Or a lot of these compacts entities have their own website. So if there's a particular compact that you're interested in and seeing what states are members of that compact, you can also go to their website as well too. So once again, thank you to our panels and thank you to our wonderful moderator, Mike Kurland from MedOne. Thank you also to our sponsors today, the Center for Connected Health Policy and the California Healthcare Foundation. And for me, thank you also to the staff who put together this webinar and made it possible, Amy Durbin from CCHP and Stephanie Thornton from Blue Path Health. And also thank you to all the attendees who attended today. Once again, a recording of this webinar will be made available in about 48 hours on the CCHP website. Yes, the PowerPoint will also be made available at the same time as well. You will receive a brief survey once this webinar ends. It would really help us out if you could fill that out. And once again, thank you to our wonderful panelists. Thank you, Mike, and thank you to the staff who helped put this together. Once again, thank you to the attendees for being here today. Have a great day. Safe weekend.
Thanks all.
Thank you.